I'm a skeptic when it comes to the critical incident stress debriefing. It was interesting just here, though. There's so much research that says it does nothing to mild harm. And yet, immediately, people were like, yeah, but I saw it do good one time. You know, snake oil did good sometimes. Truth, though, is you have to know how to do it. So one of the things that I'm going to do, which is going to be interesting, this mixed audience, I guess, on video, you won't know that we're mixed. I assume the clinicians in the front, of course, have been taught and know exactly how to do a critical incident stress debriefing. I am wondering, do the students in the back, have they been taught exactly how to do a critical incident stress debriefing? Shake heads. Okay. This is such a huge topic in police psychology. Believe it or not, look at the research as being true or flawed. Gary and I have talked, and I just think it needs to be taught. You need to be taught how to do this, so if nothing else, you'll be conversant in it. And people in the front can kind of just fade out a little bit. As anything else, you find to some extent your own style. The way I've got comfortable with critical incident stress debriefings is that I just cannot view them as curative. I cannot view them as something that's going to cure, so I view them as something that will educate. And part of that came to light when I got an email years and years ago, to just show you where lawyers will take things. Years and years ago, I wrote down this email in my response. Dear Dr. Goldfarb, they start off so nice, lawyers. I'm an academic lawyer with an interest in psychiatric industry. Oh, that's so sweet. I'm about to conduct some research into CISD and consent to treatment. In your opinion, is CISD a medical treatment in any way? And if so, would you agree that its application is subject to the same medical ethics as any other treatment? So I get this email from Barry Turner. I don't know who Barry Turner is. And I decided, and this is a long time ago. This is like the 9/11 time. Dear Mr. Turner, no. I do not agree that critical incident stress debriefings are a medical procedure. So you're getting my opinion to this lawyer who, I mean, I'm sitting there going, what do you want to drag me into? You don't even know me. You know, go away, lawyer. They would better be described as a refined and, at this point, well-practiced educational seminar presenting information that is timely after a person experiences a critical incident. The purpose of a CISD, at least as I was telling this lawyer, because I just had this desire to get him the hell off of whatever he was onto, to educate as to possible stress effects, allow an individual to see that they are not alone in their reaction, unify a group where applicable, vent feelings, gain perspective, reduce the stigma of having feelings after one experiences a situation, and point someone in the right direction if there are indications that they might be in need of professional assistance. I basically said that a CISD is not a diagnosis, it's not a medical treatment, it's educational, and that for all intent and purposes, a CISD, the way I conducted it, was very similar to the educational handouts I got at the end. And when someone gets educational information, educational literature, or educational handouts, I don't think there needs to be consent. I don't think there needs to be ethics. Well, you know, you don't want to write anything stupid. But I mean, you go up to somebody and say, here's some information on the Sun Yun Moon cult. Okay, I've given them information. Am I now liable? This is America. We can give information. We can teach classes. So that's how I become comfortable with CISD, that it's not a medical procedure. And I think that when we elevate it to that level, that's when we buck the research, and that's when we get into some type of trouble. And maybe some lawyer whom I've never seen named Barry Turner will come after you.
By the way, that is one of the concerns with CISD right now, is that there are a lot of lawyers talking about going after people, particularly after 9/11, about going after people because it's been shown in some research to cause harm. So there's going to be litigation over it if we continue to do it the same way.
Okay. Can I just do a little side thing about a technique while Jim is doing that? That has to do with, I remember I talked, in fact, you had me do a little bit of talking with your guy from New Jersey. One of the things that's going to happen, it would happen after a critical incident, but it could happen after a lot of different issues when you're counseling cops, because that's what this is about, counseling cops. And I just thought I would throw this in. I can think of two really interesting, well, I find them interesting, stories. So now an officer who comes to you for therapy, and that's going to fall into two types. In our practice, one type who comes to therapy, which constitutes 99% because of the way we're structured, they're voluntary and no one knows they're coming. In our practice, the other type, the 1% or less even, comes because they're kind of in a situation where they have to. They can't be ordered to see us because of the way we're structured, but they can be ordered to see somebody, and you know, we're probably the lesser of two evils in their mind in terms of who they can see. I have a feeling it's different in other organizations, that there are times where there's a lot more ordering. But now a question comes, how do you go back to work if you have a prolonged stay out? And I remember distinctly one captain, a New York City police captain, interesting, that was one of the first cases that New York City's program sent to me because they were just forming. And then there was Gary's client, who I did that one little piece with. The New York City captain had a very, very severe depression. He was really just not functioning. He actually was so depressed that he took some time off. And I had worked with him on a number of things. He wasn't on an antidepressant that was keeping him from suicide, but that was kind of, he was stagnant in the, I won't kill myself, but I'm not going to do much else. All of the techniques we did today, we've talked about, he added to his life. He changed some of his beliefs. He went on to try to do new things, you know. But the point was, at a certain time, he was going back to work. And he was like, how am I going to go back to work? Everyone, I said, well, okay, here's how it goes. One, everyone knows you went out for psychological reasons, so don't even worry that it's a secret. Because even though it's totally confidential, if you're out long enough, people can figure something out. Now, the next thing is, don't lie. Don't make excuses. Don't fib. No one likes that, not in the police world. I said, you know what? Use your natural resources. And one of your natural resources, the biggest one is, you're a captain. He was actually in charge of writing the policies and procedures and distribute them to NYPD. I said, you go in, the very first thing you do is you call in a meeting. You have a meeting, and you say, listen, you know, there might be some rumors that I was out because I was really emotionally kind of out of it. I want to set those rumors at rest. Absolutely true. Now that's it. No one can talk about you because they already know the truth. And so, you know, it was really hard. It was very hard being that upset and that emotionally distraught and that depressed, and that's why I got the help. And I got to tell you, that help really worked. That really, it made me feel much better, really put me back at the top of my game. Now listen, are there any questions? Because if then, watch this, because this is choreographed like this one. Now, are there any questions? If not, let's get back to work. That's choreographed, okay? Basically, at that point, people are sitting there, well, what are you going to do when the captain tells you to go back to work? You're going to go back to work. And what he found is that it did exactly what we wanted to. There's no rumors, there's no hidden talk. It was basically, once he presented himself with that assertive ability that he had, it was like, yeah, I guess the captain was really fucked up, but he's better now. That was that. And that's how you do an entry back to duty. Remember, yours is more touching. I had called, you know, Gary asked if I could talk to him, just to tell him the story of that captain. And he came back and told us his story. He went back, and he was a bigwig in the fire department. He, after this 9/11, went in there, and he kind of said, you know what we went through? You know what I went through with you? You know what we saw? And yes, I had a breakdown. My God, did my head get screwed up from that. And I got the help I needed, and I want that just to be known. I went through pain, and I'm back, and I'm doing well now. And any questions, any thoughts? Well, that was different. This kind of gets to me. Everybody stood up. And that was his re-entry back to work. So that worked very well for him. I'm going to teach you how to do a critical incident stress debriefing. The one difference is with police officers, I always do them individually. The reason is simple. If it's an event This technique by Mitchell was developed with firefighters, where typically they were responding to event to rescue. Oftentimes, the officers can get themselves in a situation where there are legal implications. And while a psychologist, as far as I know, cannot be forced to testify against his client, if you're in a group, you can pull one person out of a group and they can be forced to testify against somebody else. So you want to be very careful that you don't accidentally have a debriefing where information is going to be talked about that can jam up a cop. So you can, if you are working in a department, you can kind of do a little assessment and say, this is going to be hairy, or you can say, this is not going to be hairy, we'll do a group debriefing. There are two main goals of a debriefing. Not necessarily my goals, but now we're into the Mitchell model. This is the Mitchell model of debriefing that I'm going to teach you how to do. One is to lessen the impact of the situation on the officer, on the person. It says officer here because I work with officers. And the other is to accelerate recovery. And that may be most at conflict with the debriefing because most people will recover without it. And we don't know how much it lessens the impact. But that's the main stated purpose. There are three main values to a debriefing. An opportunity to express oneself, to give the tragedy that has just occurred a voice. If done in a group setting, the chance to learn from others, to get the whole picture of the incident so as to better organize thoughts and feelings. The opportunity to gain a better understanding of the effects that a critical incident can have on an officer. And there are 7 stages to the debriefing. It starts with the introduction phase. Now, Mitchell teaches this on an inverted U. And the inverted U, which I found, it almost confused me as preparing for this because I haven't done this in a while. It kind of like, wow, it has almost the scientific look of the Yerkes-Dodson curve. But actually, it really is just a descriptor. It has nothing to do with anything, but it's an inverted U, and it looks really good. So the axis, the y-axis is psychic depth, or the pain, or the intensity that the meeting is going to have as it kind of goes up to the stages, and at the bottom, of course, of the stages. So we start with the introduction phase. Introduction phase starts at the bottom of the U, and it's just that. The introduction phase, the people in the group introduce themselves to each other. The purpose of for the students to really go into it, you get a room, you have chairs in the room, you schedule the time, you have the people come into the debriefing room. Typically, there is a debriefer, and there is a mental health professional. Mitchell wants a mental health professional in these debriefings who sits and does nothing in case there's some type of an emergency, and then they take the person who's having the breakdown out of the room and do whatever mental health professionals do outside. Mitchell believes that only someone who is actually part of the group culture, like a cop, can do the actual debriefing, okay? So that's separate roles. The mental health professional does nothing except wait and watch. Now, in the debriefing introduction, everybody's role is introduced. People introduce themselves. People introduce who they are. I was a patrolman at the scene. I was a supervisor during that time. I'm the mental health professional. So everyone basically is introduced. And then some basic ground rules are set that, maybe we're not going to overtalk. We're going to follow a set procedure. We're going to be going through different stages. And sometimes, we're going to keep things in here confidential, and that's the thing. People are encouraged to keep confidential, but you can't guarantee that. So that is the introduction phase. Titles, places, You're smiling. Did I miss something?
No.
Oh, okay. I'm just, okay, now phase 2 is the fact phase. Let's see, there's a good place on this. The fact phase, right about there. I think right about there. Could be there, but I think it's there. Fact phase. I do find it, that's an S. Fact phase. I do find it interesting as you watch this, think of the ABCs. I've always found that interesting. You start with the person in the group, the person who's conducting it. And, you know, whatever style you have, I know I at some point developed a little bit of the using Dragnet for those who are old enough. Say, listen, we're going to go around, and each of you, from your point of view, as if you had the mental camera, because you're only talking about yourself, what happened? Stick with the facts. This isn't the time we're going to talk about anything else that you may have been thinking or feeling. Just what happened? Just the facts, ma'am or sir. And then a person is given time to tell what happened from his point of view. What happened from the next person's point of view. And it's very important, by the way, to keep the one thing I did find doing one interesting debriefing is I debriefed a wife of a cop. I debriefed the police officer wife of a police officer, they're both cops, whose husband had killed someone in the line of duty. And it was interesting because she told the story perfectly through her husband's point of view, every fact of the situation. That she needed to kind of realize she had to figure out what was happening to her. But you go around the room and each person takes a turn telling what happened in terms of that incident from their very own perspective, as if they were reporting the imagery and the facts as if they were a human camera. That's the fact phase.
No, I'm thinking.
Okay.
I'm somewhere else.
Now we go to the thought phase. My handwriting really is bad, isn't it? That's really bad. I'd be better off, you know, like the George Carlin routine, you know, picture a weather map in your mind, okay? But I want to do the averted view. Phase 2 is phase 3, I'm sorry, is the thought phase. So now we've all gone around and we start over. We start over saying to the person who did his observations for us, you know, I want you to do this again. I want you to go through this critical incident again. But what I want you to do now is, as you were going, you can kind of tell what happened again. Be briefer on that, because I'm more interested this time in what were you thinking as these events were unfolding. And of course, if you're going to do this right, you always want to make sure to say to each one, and you know, when these events were unfolding, there was a moment that you had one particular thought. And I really would like you to share with us the event that led for you to have the, oh shit thought. Because there's always an oh shit thought in these critical incidents. So now we go around the room again, and each person shares their thoughts as they were experienced during the events that they had just talked about in the previous phase. And you focus on the oh shit thought, because very often that kind of you can see where they really just had that huge adrenaline rush and all of those physiological changes. Okay. Now we're at the next phase, which is the deepest, the most intense in terms of psychic depth, has been called the reaction phase, and it's also actually the feeling phase. Now, if you've just had something happen, and if you've had thoughts about it, you're going to then have a feeling based on your thoughts, very similar to the ABCs that we talked about earlier. There is some writing that suggests that perhaps if instead of using the word feeling, you use the word reaction, you may soften it and get cops a little bit more talking, because talking about my reaction to that thought is going to be more palatable than my feelings at that stage in the game. You know what? That's a judgment call. If feelings aren't engendering a lot of dialogue, switch to reaction. It's the same. It's kind of the same thing. So now we start again for the students. We go back to the first person and we say, you know, we've all taken a chance to go around and describe our view, our vantage from the situation, factually. We've all gone around and talked about the thoughts we were having during this situation. We all shared that particular point for us where we just thought, oh shit, man. Now let's go around again and let's talk about some of the reactions that you had to this event. Particularly, if you could, some of the reactions, some of the emotions, some of the feelings that you had at each step of the way. And yet again, each person in the circle goes and is given time now to talk about the event again, specifically though, trying to get them to focus on their feelings. That is the reaction phase. Now we're up to phase 5, the symptom. That should be down there. Okay, good. A little lower in the curve, otherwise I'll run out of room. The symptom phase is, especially the mental health person might be looking for this. There are 4 types of symptoms a person could have. They got the physical symptoms. I'll talk about this more specifically in the next phase. But physical, cognitive, emotional, and behavioral symptoms. I will be very specific in a second. But now in phase 5, we're going to kind of go around the room again, and each person's going to get a chance to talk about, have they been having any troubles as a result of this? They've just talked about their emotions, but how has it affected you? Well, what has happened to you that's really, you think, worrisome, bothersome, frightening, scary, impacting? So that is the symptom stage that looks to find the symptoms the person may be having. After we go through everybody, phase 6. Is the teaching phase. Now the person who's running the group may actually finally do a bit more talking and can actually suggest that as a result of very severe stress, we can get a lot of different symptoms and things that they can possibly look at. Behavioral symptoms, decreased job performance, withdrawn from friends, colleagues, family, outbursts of crying or laughing, changes, this with cops I see is one that really hits, changes in normal humor patterns, okay? If you've always been someone doing sick jokes and you're continuing with that, it is not a problem. If all of a sudden you're like, I don't want to offend anybody, after an incident that could be a problem. Excessive talkativeness or silence, hyperactive frenetic behavior. That would be behavioral signs. Physical signs, tension, aches, pains, trembling, jumpiness, a startle reaction that's increased, cold sweats, dry mouth, stomach issues, vomiting, diarrhea, feeling tired, fatigued, and of course the 1,000-mile stare. Cognitive signs, difficulty making decisions, confusion, disorientation, poor concentration, memory loss, cannot perform multiple tasks easily, again, if it's something you used to be able to do, and flashbacks, either visual or auditory, and emotional signs, which would make sense, grief, guilt, depression, anger, resentment, fear, feeling overwhelmed, constantly self-guessing, self-doubting, and feeling detached from reality. So part of the teaching phase is to kind of go over all of these symptoms that they can have. This is the time to give out written material. Things commonly taught in the teaching phase are, a lot of you are going to have reactions, but they're normal reactions to an abnormal event. Where to go for counseling, where your wife might go for some extra help, what different support groups are available, all of the department or all of the resources that might be available at the teaching phase. This is the time that you're supposed to be distributing this information. Yes, a question.
I know this may be different for specific departments and stuff, but is there a specific time period after an incident that this critical incident needs to be done?
That's been argued so
Okay.
much.
Right after?
Let me see. The question was, Is there a specific time frame after an incident in which the critical incident stress debriefing should be performed? I believe that Mitchell's, when this first came out, and I'm doing the original Mitchell model, I believe, and Gary, please, because I'm not sure of this, I believe it was 72 hours. I don't know if that's what they're adhering to now. I think it's gotten a little bit longer. But when it was first taught, the Mitchell model was 72 hours.
It's changing from a week. I've heard as much as a month. Everybody's got a different way of looking at this. It's just sometimes shortly thereafter when it makes sense. That's when you do it.
But for textbook reasons, Mitchell's first teaching was 72 hours. One of the things I think has happened in the research is that we're seeing that one of the things that was really, really beneficial to people, which is not in the Mitchell model, was dealing with creature comforts. You know, shortly thereafter, do you need some water? I'll give you a big thing to do right on the spot that really is very, very important. So now the officer is involved in something and you say, do you want me to call your wife and let her know you're okay? You're okay. Yes, yes, I do. What's the logical problem with that? Your wife doesn't even know there's a problem. But he wants the comfort of knowing that his wife is going to know that he's okay. He's worried about her, what he can do to help her. Very powerful technique. But it's very simple. It's not very dramatic. Do you want some water? You want to sit and talk? You're cold. You need a jacket. Do you want some food? Those types of aid are becoming what we see might be the most important thing to do in the shorter term. So that 72-hour mark has been moved. But I want to answer your question so you say, I know how to do the Mitchell model. Okay. Now we're at the last stage, which is the re-entry. We're at the re-entry, the final phase. And you see now we're kind of relaxed. The group is relaxed. We had the big, because we've gone through that inverted U. We've gone from the little bit of, you know, kind of normal feelings when we just walked in to getting more and more and more tense till we were talking about our feelings and then the symptoms, and then we're kind of coming out of it. So we've taken people through this entire process. And the re-entry phase deals very, very specifically with, okay, now that you've kind of gotten all this out, you're going to be going back to work. Can we go around the room and everyone say what they think might be an issue or a problem of going back to work? What might be a problem for our spouses or our children? What can we do, practically speaking, to get back into the game, to get back into the system in a way that's most orderly and is healthiest? And at that point, everyone shakes hands, we leave, and the vast, vast majority of people you've done this with feel that you've cared about them, that you did something for them, that they had a good experience because they did vent a little bit, and they're very, very happy and very, very satisfied. And does anybody remember the Hawthorne effect?